It's a pleasure for me to introduce one of the many division chiefs that we've trained across the U.S. Opie Olabisi. Opie did his MD, PhD at, at Einstein, followed by residency and fellowship with us at the MGB program, with a very productive research training, and then got recruited by Duke, where he is now the division chief. And he's extraordinarily well funded in APOL1 disease and other subjects by both NIH and industry. And he's going to talk to us about APOL1 and kidney disease.
Thank you very much, Dr. Mount. I have fond memory of rounding with you at Brigham Women. We had a lot of fun, so it's great to be back here. So let's see. So my topic, as you have it, is APOL1 kidney disease, and my introduction is as provided. This is my disclosures. Because I work on APOL1, I do both NIH-funded work and also industry-funded research. But none of those will have implication on what I will be saying today, but you should be aware of my conflict. What I'm hoping to do today, I know this is the last session for today, and I'm hoping it will be worth your while. There are not very many diseases in nephrology that we can say we can date back to just 16 years, less than 20 years. I was thinking back to this session that when the APOL1 field opened up in 2010, Obama was the president, so it's still yesterday. But since then, things have really picked up significantly. If you see patient in the United States and you see patient of African ancestry, largely Black, but also patient from South America, as you would see, this would be very important for your practice, and also for all of us in general nephrology. So my hope at the end of this talk is to accomplish four things. One, that you recognize the spectrum of diseases that we now describe as APOL1-mediated kidney disease, AMKD. Two, that you'll be able to explain the genetic risk as well as the incomplete penetrance. Why is it that only some people with this risk variant develop kidney disease and not others? Thirdly, that you'll be able to apply selective testing in your clinical setting as well as in transplant counseling. And you'll see that this is actually one of the areas where the knowledge of this disease and this gene will be important. So if you have patients that potentially want to be potential living donor, this is something that will be relevant. And lastly, to evaluate the current and emerging therapies. So within 10 years or now 16 years, we have a couple of trials now looking for therapy. This is really a breakneck speed in nephrology from inception or the description of a disease to basically working on mechanism to identifying therapy, and we're excited about that. So I will be previewing for you some of the upcoming attraction, if you will, therapy-wise. But let's anchor this next 30 minutes or so with this clinical vignette of a 39-year-old non-diabetic African-American male with history of hypertension and FSGS, who present for follow-up visit. His proteinuria has been stable at 0.8 gram per day, but his GFR has been declining. 3 years ago, it was 45, now it's 35. It's on optimal blood pressure management, it's on lisinopril and clothalidone. So he's a well-informed patient. So he asked you the following question. Well, he said, what is the likelihood that he has an APOL1 high-risk genotype? So he's been sort of maybe reading about this. And two, would you recommend APOL1 genetic testing for him? Thirdly, does APOL1 genotype affect his prognosis, especially progression? Thirdly, what should he do now? And lastly, let's say he came with his brother, who is probably willing to be a living donor, or a friend who's willing to be a living donor. Does the APOL1 genotype affect kidney allograft outcome? And does it also affect what happens to the donor afterwards? So these are not just intellectual questions. These are questions that I will guess that many of you have already received or will be receiving in clinic. As a way of a background, many of you know that African Americans, and many presenters today have mentioned the same, have very high risk of end-stage kidney disease. It's about 4 times higher than white Americans. And this is not a one-factor disease, meaning that multiple things contribute. Structural and social economic determinants, unequal access to preventive care, hypertension, we just heard about diabetes, but also genetics. So some of us that are trafficked in genetics can make things sound like it's all genetics. It's not all genetics. But at the same time, we cannot be dismissive that the effect of genetics, especially in this case, APOL1, is quite powerful. It doesn't explain all the excess burden of kidney disease in African Americans, but it explains a lot of it. And so there's been indication that there's probably genetic composition. And this study in 2010, led by my old mentor, Martin Pollack, who also was previously a member of Brigham Women's Hospital before he moved over to Beth Israel, in a study funded by NIH, basically doing admixture mapping, identified that 2 variants of the APOL1 gene called G1 and G2 strongly associate with the incidence of FSGS and hypertension attributed kidney disease in African Americans. So let's peel back a little bit. What have we learned so far? So most people have G0. The original APOL1 is G0. And based on the current model, it's believed that around 5,000 to 10,000 years ago, the G1 and G2 evolved as protection against African trypanosome parasite that causes African sleeping sickness. So as far as we know, the evolutionary benefit of this variant is to be protective. So they are part of innate immunity against African trypanosome parasite. And the origin is mostly in the West Africa, which also covers a little bit of southern part of Africa. But the timing, as far as we can date it, is around 5,000 to 10,000 years ago. And so on the right side here, I show the 6 possible genotype that an individual may have. So you get one from father, one from mother. So either G0, G0, or G0, G1, and so on. But the genotype that are strongly associated with kidney disease is when you have either a G1, G1, a G1, G2, or a G2, G2. We call these 3 genotypes high-risk genotype because of that association. Now, I mentioned that the origin of this variant dates back to around 5,000 years ago or so. You may remember that out of African migration that populated Europe and the rest of the world dated back to around 20 to 100,000 years ago. So the out of African migration to Europe, to Asia, and further occurred much earlier than the origin of APOL1. So this is why the G1 and G2 are not naturally present in people of Asian or European ancestry. During the Middle Passage, the transatlantic slave trade, the genes were taken with people from West Africa to the Americas, but also what this map did not show, also to South America, to Brazil and Argentina. Even though people there may not look Black, but the ancestry, that gene still track with them, which is my first point here, that this is not just a Black gene. This is an ancestry gene. So if you have a patient or an individual that have recent West African ancestry, and how do we define a recent? By this migration, if it's within the last 400 years. If you have ancestry that came from West Africa or East Africa or Congo area rather, in the last 400 years, there's a likelihood that this gene came with them. So in the US, we see this among African Americans. but also in South America, where the slave trade also took people down to Brazil, Argentina, and other regions in South America, the APOL1 is also highly prevalent. So again, a reminder here to point out that ancestry and race here are not equivalent. Think of it as ancestry gene. So if you see someone who say, well, I'm from Brazil, and you see later on that there are some hints that should probably trigger the thought in this line. FSGS, even though it's a pattern of injury, and somebody who you are not sure doesn't have West African ancestry, you should think of APOL1 in that context, and you'll see why. Now, not everyone that have this high-risk genotype develop kidney disease. So genotype is not destiny, right? So we should keep these two thoughts in mind. Now, we try to avoid, again, as I said before, so we want to say things like recent African ancestry rather than a Black gene. For two reasons. There are Black people that do not have this. And two, there are non-Black looking people that have West African ancestry that do have this gene, right? So it can sort of misguide us. Now, somebody might say, but in the US, most people that have this gene, this Irish genotype, will be Black, and that would be accurate, right? But race is a very imperfect marker for who has this and who doesn't. It just turns out in the US, it's a very useful marker. The other thing I want to mention here, again, we want to avoid genetic determinism. That is, not everybody that have this gene develop. Actually, the number is about 15 to 20% of people that have two risk allele develop kidney disease. And also, if we perform the test, we should make sure that we seek consent of the patient. There was a case that was referred to me where somebody in the process of transplant evaluation was tested for APOL1, but he was not informed that this gene, and the site also took that into consideration in denying the person transplantation. So there was it was a gnarly situation. So part of doing this testing should involve informing as well as obtaining consent. Doing the testing also is a gateway to trial, so it's very important as I will mention later. So two variant confers the greatest risk. So the mantra for the past, I would say maybe the bulk of the last 10 years, the early first 10 years is that among the 13% of African Americans that have two risk allele, that's about 6 million people in the US, about 15 to 20% of them develop chronic kidney disease. Now, what about one risk, people that have G0, G1 and G0, G2? The initial study shows a very minor increase, but not significant. So we think of this disease in general as recessive, that you have to have two risk allele. But recent evidence from West Africa suggests that among some people, one risk allele also may confer risk. But so this area requires more work in the future. But for now, I think where the evidence is strongest and where the evidence is most actionable is the two risk allele. We will begin to learn more with time the implication of one risk allele. In West Africa, it seems to have significantly higher risk, especially for FSGS, than in the United States. So first question, which of the following form is not associated with APOL1 iris genotype? A, hypertension attributed kidney disease. B, increased incidence of diabetic kidney disease. C, COVID-19 associated collapsing nephropathy. D, HIV associated collapsing nephropathy. And E, lupus associated collapsing nephropathy. All right, I see. Okay. Give a minute or two, and then I'll move on to the next slide. Okay. All right, I see a toggle between between B and E. All right. So people that, and you'll see in a moment, this will probably change some of the answer as we go along. So the spectrum that I was referring to, on the one hand, so focal segmental glomerulosclerosis, as you've heard earlier, it's not a diagnosis, but it's a pattern of injury. But it turns out to be a pattern of injury that's quite important in this context. So if you see 100 African Americans in your clinic that have the diagnosis of FSGS, remember I mentioned before, in the general Black population in the US, only 13% have high-risk APOL1. Among Black patients with FSGS, 40 to 60, in some cases, 70% have two-risk allele APOL1. So there's a strong association between the high-risk genotype and FSGS. So like these patients that we have in the discussion, so the pretest probability that this patient has high-risk APOL1 ranges, up to 70%. So the pretest probability is pretty high. Now, the other category of disease that fall in, again, a glomerular disease, if you will, is collapsing glomerulopathy, namely with HIV-associated nephropathy. And this tend to be seen in uncontrolled HIV. With viral control of HIV, this association actually falls apart. So it tends to be that the viral load is related to how HIV confers this risk. We believe it's through the viral effect itself and through the interferon effect as well. During COVID-19, there's emergence of collapsing glomerulopathy, where many people across the country, this is in the early days of COVID, about 90% of all patients that develop collapsing glomerulopathy have two-risk allele APOL1. And there are incidences of patients that receive interferon, either interferon alpha, beta, or gamma, as part of therapy, that some patients develop collapsing glomerulopathy. Retrospectively, when they were sequenced, they found that they actually have high-risk APOL1 genotype. So collapsing glomerulopathy, think of presence of APOL1 high-risk genotype. Also, lupus collapsing glomerulopathy as well. Not typical lupus nephritis, but the collapsing variant, or even type 5, where you have more of the podocytopathy of lupus, is also associated with APOL1. Now, what about diabetes? Somebody might say, well, that's B in the previous question. It turns out that APOL1 high-risk genotype do not increase the incidence of diabetic kidney disease. But once you have diabetes, progression increases significantly. So APOL1 is associated with rapidly progressive diabetic kidney disease, but it does not increase the incidence of diabetic kidney disease. Now, the last category that I should mention here is the category that we used to describe as hypertensive nephrosclerosis or hypertensive CKD, which is highly common among African American. I remember in medical school, a Black patient presented to the emergency room with high blood pressure and found to have GFR of 20 and maybe a little bit of proteinuria. The presumed diagnosis is like he has hypertensive nephrosclerosis. It turns out that 40% of those patients have two-risk allele APOL1. And an animal model where APOL1 is expressed in the endothelial compartment by Katalin Zustak, the phenotype that was seen is actually very similar to hypertensive nephrosclerosis, suggesting that APOL1 itself is a driver of this phenotype rather than hypertension causing the disease de novo. So the answer here is increased incidence of diabetic kidney disease. APOL1 is not associated with the incidence, but it's associated with a rapid progression of diabetic kidney disease. So it's important when you have a patient that has diabetic kidney disease that is probably atypical, or even if it's not typical, given that diabetes is very common on one hand, and APOL1 is also very common, there will be some patients where their disease is actually APOL1 kidney disease that's under the maybe being masqueraded, if you will, by diabetic kidney disease. So there should be some index of suspicion among Black patients or patients that have West African ancestry, that have diagnosis of diabetes and kidney disease, one should not automatically assume is diabetic nephropathy. There could be component of APOL1 there. I mentioned before that one of the impact of APOL1 overall, beyond the increased incidence of kidney disease, is the rapid progression. So it's an accelerant. So even in the CKD not otherwise specified, patients that have high-risk APOL1 progress to dialysis about 7 to 10 years sooner than other Black patients that do not have high-risk APOL1 genotype. So there is a prognostic benefit to knowing whether your patient with CKD do have high-risk APOL1 genotype, because it can help you to risk stratify them. This may be a patient that you need to do whatever you can to slow down their disease. Now, I have to admit that there's really no FDA-approved therapy at this time, but at least you'll be aware that this patient is a slightly higher, in fact, significantly higher risk than a CKD patient with low-risk genotype. I mentioned that not all carriers of APOL1 develop kidney disease. So if you look in the US and you'll find the individuals that have high-risk APOL1, about 15 to 20% of them develop kidney disease in their lifetime. We don't know precisely what separates this 15 to 20% from the other 80% that essentially get out of the jail card. But what we also know is that APOL1 high-risk genotype is necessary, but it's not sufficient for the disease. So you have it, yes, but something else needs to happen. So we call those second hits. And some of the second hits that we know, I already mentioned some of them, HIV, people that have uncontrolled HIV, that have high-risk APOL1, half of them will develop HIV-associated nephropathy. But you notice I said half, not 100%. So Jeffrey Kopp actually had this cohort at NIH, and his work was really illuminating, allowing us to know that HIV is the strongest driver, second hit driver of APOL1-mediated kidney disease. COVID also was a very powerful driver, interferon, as well as conditions that raises the, systemic inflammation. I would say that we still don't know the identity of some of this. Now, these are the viruses we have identified. There are some report of parvovirus, but I wonder whether there are other viruses that also can act as second hit. So there should be high index of suspicion. Had a patient that present with acute presentation with proteinuria, and all she can say is that she has pertussis. At least by diagnosis. I don't know whether that's actually not been reported in literature. But again, we should have high index of suspicion of conditions that raises systemic inflammation. And so the combination of APOL1, which is the first hit, and then some kind of factors that raises inflammatory milieu, serving as second hit, causes APOL1 to be expressed in the kidney, especially in the podocyte. And the expression of APOL1 in the podocyte is from both experimental model and what we see in human seems to be very crucial for the pathogenesis of APOL1-mediated kidney disease. So the pathway is listed as shown here. Inflammatory cytokine, upstream of this may be viruses, upstream of this may be other factors. Again, we haven't really fully discovered all those factors. Working through JAK-STAT pathway as a well-delineated pathway that drives APOL1 expression, especially in the podocyte and also in the endothelial cells. But the podocyte is exquisitely vulnerable to the effect of APOL1, the G1 and the G2, driving podocyte injury and causing podocytopathy. So the therapeutic implication is therefore suppressing APOL1 expression upstream, either by blocking this pathway or by blocking APOL1 function downstream. And I will show that what the literature or what the studies have shown us is that APOL1, once it's expressed first by the upstream trigger, let's say this is the plasma membrane of the podocyte, APOL1 forms ion channel in the pore, in the plasma membrane of the podocyte, causing potassium to efflux and sodium to influx. Especially the efflux of potassium seems to be very crucial to the toxicity that comes below, to the subsequent podocytopathy. So the evidence now suggests that blocking this pore function is key. And I would say, and I think I have this in the next slide, there was a recent mutation in the APOL1 that is called N264K. So this N264K is a change of amino acid at the 264 position, but in the G2. When there's a G2 and has N264K, that N264K kills this pore function. And you would imagine that people that are lucky to have this mutation, they don't develop kidney disease from APOL1, adding evidence that this pore function is actually very key to the pathogenesis. And that's pretty much what I'm showing here, that the N264K reduces the toxicity of G2 by blocking its pore function. But you can also imagine if we can block this pore function pharmacologically, and that's what the drug inaxaplane by Vertex, that's what it does. So there's an ongoing clinical trial that is testing the efficacy of blocking this pore with drug, with small molecule. Another company, Mace Therapeutic, is taking the same strategy. All right. So we use several models to study APOL1, and in the rodent model, and when you induce APOL1, G1 and G2 in mice, what we see is that we see FSGS. If we put G0, we don't see anything. So the G0 in mice is not toxic, but the G1 and the G2 are. So these models are really very useful for testing drugs that potentially can be useful in human. And this is really what most of us in the field have been using. We also use a human kidney organoid. All right. So when should you consider APOL1 kidney disease in your patient? APOL1 kidney disease, at least in many of our minds, is the disease of the young. Well, before COVID, we think that most people that develop APOL1-mediated kidney disease already have some kind of manifestation by age 50. Of course, that's not a clear cut, but it sort of shows that it's a disease that happened pretty much early or manifests by that age on average. When you see the histological injury pattern of FSGS or collapsing glomerulopathy in the right context, in a Black person or in a South American person, or somebody that you think may have West African ancestry, you should raise your index of suspicion for testing APOL1. Rapid progression, remember, it's an accelerant. So even a CKD that is progressing rapidly, like this patient, GFR going from 14 to 45 to 35 pretty quickly without any clear explanation, or family history of chronic kidney disease, dad or uncle or grandma, you can see that lineage effect should also prompt the index of suspicion for APOL1 genetic testing. I already mentioned HIV, COVID, and lupus. So caution. Now, I mentioned podocytopathy, but not all APOL1 have very high level of proteinuria. The level of proteinuria can be variable to things in the low 100 up to a few grams. Now, histology is not genotype specific. In some cases, you see focal segmental glomerulosclerosis. In some other cases, you see focal global sclerosis with solidified histology. So there's no pathognomonic kidney histology that sort of say, well, this is APOL1 and nothing else. The one big basket I really want to mention is whenever you have it, you probably see it in the notes, or you yourself are thinking, well, this patient probably have hypertensive CKD. In a Black patient or the patient that fits the profile I mentioned, think maybe this is a situation I should test for APOL1. But genotype alone does not establish causality. KDIGO guideline suggests testing, that testing may inform diagnostic interpretation, as I mentioned before, risk stratification. So a patient that has CKD with high risk APOL1 is on average more likely to progress faster than patient without. So knowing that genotype is actually very important. Living donor counseling. So there is a question as to what happens if somebody who has high-risk genotype, let's say G1, G2, want to donate a kidney to somebody else. Does donation itself constitute a stress, or does it constitute a trigger of disease in the donor? I would say the evidence here is not closed, but we used to have one paper, but now we have two. The first paper suggests that among living donors, a very small study by Munadoshi, among living donors over a period of about 12 years, around 10% or 10.5% of the living donor with high-risk genotype develop end-stage kidney disease themselves post-donation, which was quite a high number compared to people with low-risk genotype. So that number was alarming. But the APOLO trial, people from within that study recently published a study in JAMA. And this study just came out a month ago. So I'm not even sure I was able to put it in here fully. That shows that if you look at living donors and you follow them for 20 years, this is a retrospective study, and they went back to kind of call back to look at their GFR, setting GFR of 45 as a threshold to say what is the likelihood of your GFR dipping below 45 over that period of time. It turns out that having two risk allele APOL1 increases the likelihood by twofold compared to people without. What does that mean? So it's not everybody that have the high risk, but this is an aggregate. It means that if somebody wants to donate a kidney as a living donor, we probably need to offer them the test for APOL1. Now, what if the person said, well, I don't want to do the test? Well, I don't think we should make it a prerequisite. I don't think we should make it mandatory. But I think we should let people know that this evidence, as incomplete as they are, suggests that there might be an increased risk of post-donation risk of kidney disease in the donor himself or herself. So we should inform and we should offer the test, but also provide the obtained consent before we do it. I think we get into trouble if we do it without the person actually understanding what we are doing. Clinical trial, I think this is also a very big benefit. Since there are no FDA-approved drug, there are now about 3 or 4 clinical trials going on. All of them requires genetic testing for APOL1, which is easily done. So I'd say that doing this in clinical practice is becoming relatively common. And Natera has this on their platform, and many of these clinical trials actually also provide free genetic testing for APOL1 so that you can offer it to your patient, making it possible for them to participate. So evidence remains sufficient for routine population screening. I think this may change after there's the treatment. But part of the rationale here is not all carriers, in fact, majority of people with high risk don't develop kidney disease. So the sense is if you now screen everybody, and you said somebody has high risk genotype, would we just be raising anxiety in about 80% of people that will not develop kidney disease? I mentioned the testing without informed consent. I think we should avoid that. Providing informed consent before testing or obtaining informed consent is necessary. Predicting disease genotype from genotype alone. So somebody that is healthy, that has high-risk APOL1 genotype, we have no way currently to predict if that person will develop kidney disease in future. And lastly, automatic exclusion from donation. I think this is a really sensitive topic. Most people that receive living donation receive from a relative, about 70%. So if we exclude people that have high risk APOL1 automatically, and remember, somebody that actually has a relative that has high risk APOL1 genotype is more likely to himself have high risk APOL1 genotype. So this is an area where I think care needs to be taken. We need to inform the potential donor, and I think we need to offer the genetic testing. I think it's a shared decision making. The person may decide to not get tested, but that should not constitute automatic exclusion. All right, so testing is a counseling process. So before we cancel, we get the result, we return the result to the participant, and we have to have a plan of what we'll do after we obtain the result. So if a patient has to risk allele, to have a way to explain to them what that may mean. in transplantation, I think I've spent some time on this in terms of the two-risk allele APOL1. There's one study in 2025 that suggests that recipients with one risk allele or two risk allele also may have increased risk of kidney disease. This is a very serious study from a group at Yale, well done study, but I think we need validation from other group before we consider the importance of two or one risk allele in the recipient. But this is raising an area where I think we need to pay attention to APOL1. Pardon the typo here, transplantation dynamics, so donor versus recipient risk. So I'll go through this very quickly. So for recipients, the preponderance of evidence suggests strongly that it's the APOL1 in the donor kidney that matters, in the diseased donor. And the donor kidney that has two risk allele APOL1 on average do poorly more than the ones without the high-risk genotype. But here also, that risk is not 100%, it's not fully penetrant. It's also associated with rejection. This is a work done by Ibrahim Batel at Columbia, suggesting and showing clearly that a high-risk APOL1 genotype in the diseased donor is associated with increased risk of rejection and graft loss in the recipient. But this is also part of the hopeful benefit, we hope, of treatment with APOL1 kidney disease. Living donation, I think I mentioned informed consent, and that's really a very important point to make sure that potential donors are aware. I won't dwell too much on this further. Another knowledge check. Which statement best reflect current guidance on APOL1 testing? A, screen every person who self-identifies as Black. B, a two-risk variant genotype proves APOL1 caused the kidney disease, CKD. C, use selective testing when results may inform diagnosis, prognosis, donation, or trial access. D, exclude every potential living donor with two-risk variants. Okay. Well, I'm curious to see what people will say here. I'll give it maybe 10 seconds, 20 seconds. Okay. Yeah. So in the interest of time, yes, the answer is C, use selective testing. And somebody might say, what about B? Well, it's not everybody that develops CKD and has high-risk APOL1 indeed does have APOL1-mediated kidney disease. So that's really the trick there. But C is most accurate if or when it informs diagnosis, prognosis, donation, or trial access. I think those are the best evidence-supported testing for APOL1. What are the treatments that's available for APOL1 currently? I'll say none. No FDA-approved drug. What I should have also added here, and I think Dr. Glassok might have mentioned it, was sparsentan. Now, sparsentan in duplex post-hoc trial shows that compared to irbesartan, there is a better reduction of proteinuria there. But I would say that this was not a randomized control study that's looking specifically at APOL1. There was only 14 patients in that study that were high-risk APOL1 genotype. But I would say, though, that if I will put a patient on RAS inhibition, I'll probably choose sparsentan over, which is, of course, a combined ARB plus endothelin receptor, but there might be indication to use that instead of regular RAS, single RAS inhibition. SGLT2, blood pressure control, none of these have been proven to slow the progression of APOL1 kidney disease, which is why ongoing trials are important. But not the same, or all the same, we should still make sure that we have the patient on the current guideline standard of care. The three studies or the three therapeutic, this is the promise of what's coming, upcoming attraction. These are three categories. I mentioned to you that upstream, you have inflammation working through JAKs that drive APOL1. So the JAK inhibitor, which is a study that I lead, is looking at the efficacy of repurposing baricitinib to block APOL1 production upstream. So that's JAK inhibition. Next is once the APOL1 is made, can you block the mRNA using antisense oligonucleotide? So there are studies now by AstraZeneca testing a phase 2 trial using APOL1 antisense oligonucleotide. And thirdly, inaxaplin, which is a small molecule inhibitor of APOL1 pore, as well as MZE829, which is also doing the same thing. So all these trials are going on as a way to test whether or maybe all of this can slow the progression of APOL1. So it's an exciting time. And these trials are sort of listed here with the phases in your handout. Can we predict APOL1 in the future for somebody? We're not there yet, but there are promises that this may be possible. This is a work from Katalin Zustak lab that says that if you look at, can we use proteomics? Can we use proteomic signature before this patient progress rapidly to see who is likely to progress with APOL1? And this work is proposing that maybe in the future, we may be able to do that. And that's quite promising. And so if we go back to the patient that we started with, and we answer this question, so what is the likelihood that this patient has high-risk APOL1? I would say very high. The pretest probability is high. It's an African American with biopsy showing FSGS. The odd ratio or the likelihood is about 40 to 60, in some cases 70%. Would you offer APOL1 genetic testing? I would say this is reasonable because if it's positive, maybe you will be able to participate in trial, and it also gives you a sense about what it may have. Management, I would say standard of care, but none of this have been really proven to be specific to APOL1. Prognosis, if he has high-risk APOL1, this probably will predict faster progression. And for transplant, if he comes with his brother or a family member, I think we should offer that person genetic testing after obtaining consent. And so let me just end with the take-home point that the genotype identifies susceptibility, not destiny. Not all carriers have it, but it's a very important markers to have in mind. 2, test selectively, cancel carefully before testing, and for now, we treat comprehensively until we have targeted therapy. And those two studies, the APOL1 directed therapy, are moving forward. So hopefully we'll have those in the coming year. But I encourage everybody to participate in those studies. That's how we'll know whether they are effective. And that's my last slide with references. Thank you for your interest. I'll take questions.